revolution has begun. Forward we go, breaking the chains, turning the tide, igniting the change. Science and heart leading the way. Empowered we rise, no more delay. Oh, forward we go. Beyond the old ways, beyond the past.
Very happy to introduce you to our guest for this session, Dr. Jennifer Dietrich, the College of Medicine in Texas, and she has done a lot of work with adolescents, helping them with endometriosis. She was actually a co-editor with my brother, Dr. Nezhat, in the book about adolescent endometriosis. And we are going to start from there. And she's going to further tell us about her work, what she's doing, and what does she see the future. And she did an outstanding presentation at the American and Global College of Endometriosis Specialists in Las Vegas. Jennifer, go ahead. The podium is yours. Go
Absolutely.
ahead.
Well, thank you, Dr. Nezhat, and I really want to thank the Scientific Planning Committee for having me at this conference this year. It's the first time joining this group, and it's been really wonderful to share ideas and to hear about some, real life experiences from patients as well. I think that, in my role, I have been focused my entire career on the pediatric and adolescent population. And so after completing my fellowship at the University of Louisville, where I had the opportunity to subspecialize after doing my residency at Baylor College of Medicine, I was really one of the first OBGYNs completely immersed in a children's hospital setting. And therefore, all of my patients were under the age of 21. And there were many, many unique problems. They weren't the same problems that we were seeing in adult women. There were certainly gynecologic conditions, but they looked different in children and adolescents. And certainly with regard to endometriosis, it looks a little bit different too, in that their symptoms may start earlier than we anticipate. They may mimic other symptoms that are just a bit more common, related to genitourinary symptoms or gastrointestinal symptoms. They might also mimic themselves in different social or psychological ways. And so we have to listen to our patients really critically in order to make a diagnosis early. That's ultimately what we want, is to make a diagnosis early. We have the tools as pediatric and adolescent gynecologists to recognize some common themes and patterns in this patient population. That includes congenital anomalies of the reproductive tract, which we often may have a chance to impact because these patients with obstructive anomalies are coming to our ERs. We don't always diagnose things the same way in adolescence. And so perhaps, while we might lean on transvaginal approaches to make a diagnosis in an adult woman, that's just often not possible in a child or an adolescent. So we're leaning on transabdominal ultrasound or MRI to aid us toward taking the next steps. If we're planning on surgery, whether that's correcting a congenital anomaly, relieving an outflow tract obstruction, which certainly poses a risk for endometriosis in the future, or simply we don't anticipate that a cyst that should have gone away has resolved, and in that situation we might be suspecting an endometrioma. And in the setting of persistent pain after trialing, combined hormonal methods, or any hormonal method for that matter, certainly dependent on the patient's ability to take an estrogen-containing option or not, we really have the opportunity to make a diagnosis early, and these lesions look a little bit different than they do in the adult women. So we need to heighten our awareness. We need to have some special tools in order to pick it up. And we have to keep in mind this fragile population's fertility for the future. So always keeping that in mind and maybe taking the approach with precision and individualizing our approaches for the patient.
Thank you very much, Dr. Dietrich. You have been so proactive in helping patients, young patients, pediatric patients with endometriosis in their diagnosis, in their treatment. And I know you are doing such a great job. Here in this meeting, we are talking about the role of artificial intelligence and the endometriosis risk advisor app that we are using to help patients with endometriosis. So how do you see the role of AI being in this meeting? I don't know if you have been familiar with the endometriosis risk advisor app that we launched in 2019 for adolescents and also for all the patients with endometriosis. Have you ever used it, or what do you think about it? Or if you have not used it, are you planning to use it?
Yeah. So actually, I'm really excited about the app and I cannot wait to use it. I am really sad that I didn't know about it before, but I definitely think that, in the modern day, there is a role for AI, and I think it will help us not only with kind of care pathways and patient navigation, perhaps aiding the clinician with just better tools to collect the history. Sometimes, these are integrated into the EMR, ambient listener tools. And really, when we're sort of interviewing our patients, gathering that history, that critical history, sometimes there are certain components of that history that might get left behind. But many of these ambient listening tools gather everything. So we don't miss anything in the medical record, and it's really kind of in the patient's own words or the mother or father who might be also contributing to that history because of their daughter in front of them. And so I think that is an exciting tool that will probably improve in the future. And while right now I know that it's a little bit more focused on scheduling and efficiency and perhaps gathering data, summary formation, all of those things are going to make it easier on the clinician. But there's no question that standardization in the future is really what will be needed in order to reach more patients, in order to make an accessible option available to patients everywhere. And that accessibility needs to be standardized. I completely agree with that. And so I cannot wait to see what will happen with the evolution of AI in medicine.
More and more patients. So in general, right now, when you do treat the patient with endometriosis in adolescent, tell us your guidelines. What do you do for them? What do you tell them?
Yeah, absolutely. Well, I think that, not everybody wants surgery right away. And I have definitely a group of busy adolescents. They're involved in soccer, dance, ballet, many, many different activities. And they're not always excited to proceed with surgery. And so we have to work with the patients and families a little bit about their schedules and their lives. But at the same time, they realize that, perhaps if a pain episode happens during a game or during kind of a, performance, they're not at their best, they don't feel well, or they might have to skip it altogether. And so, we do often try medical management for several months before proceeding with a surgical approach. And then we have many, many different tools in our toolkit as gynecologists to use the smallest possible trocars as we embark on a laparoscopic survey of the pelvis. That includes everything. We look in the upper abdomen, we look in the lower abdomen, and we submerge the camera under, kind of a fluid medium within the pelvis to look for endometriotic lesions. The clear lesions are the hardest ones to pick up. And that's how you can magnify the approach and magnify your ability to detect endometriosis in this younger population. Even if we see nothing, we always biopsy. We try to take a little piece of tissue in several different common places. The cul-de-sac is a common place. We know that the pelvic sidewalls and ovarian fossa are common places as well. And so that will aid our diagnosis capabilities, even if it's only picked up histologically. And then certainly, while we are taking a biopsy that's generally excisional for diagnosis, if we see lesions, typically these are clear or red or yellow-brown, then precision has really been sort of what I have trained in. And that sort of theme and that approach has been one that even my mentors have echoed to me over the years as protective for fertility one day. It is very precise, and lasers are a tool for that. So lasers can help minimize thermal damage and minimize damage to surrounding vital structures like the ureters and the intestines. You know, we really kind of try to protect their fertility. That's the goal.
Well, thank you again. You are being in this meeting of the American and Global College of Endometriosis Specialists, and you have been again presenting and listening. What has been the most surprising point that here you noticed in this meeting, and what you are excited about, and with all these participants here, so that they are here from all over the world? What are the points that you have liked in this meeting?
Yeah. Well, I mean, I think that some of the modern approaches that are on the horizon with use of AI as one of those modern approaches is really going to help us better communicate with patients, number one, and better coordinate activities that we need to coordinate with patients, helping them move through pathways. We see this a lot in many of our multidisciplinary clinics at the Children's Hospital, but this is no different. It really does involve a multidisciplinary approach. So I think that's definitely one thing I'm excited about. I am also excited because, you know, there are perhaps tools on the horizon that can help us make a diagnosis or assess a risk for endometriosis with, you know, perhaps doing a buccal swab or a blood test. And so I think that some of these studies that might allow us to detect it without proceeding right away to surgery, or at least giving patients some sort of risk assessment before proceeding with surgery, can be really exciting, because every day I definitely have to tell my patients, we don't have a blood test yet, or we don't have a diagnostic tool to say that you are at risk for endometriosis or you have endometriosis. We really just have those things that have borne out in the literature that certainly go along with congenital anomalies, a family history, persistent dysmenorrhea that is unexplained, or chronic pelvic pain that is unexplained. So there are all of those symptom-based strategies, but these other exciting strategies are amazing.
Therefore, what do you tell parents or others who, when they have been normalizing and gaslighting the pain in the adolescent and young patient, and that they tell them, oh, this is all normal, you grew out of it, this is in your head, this is all normal, the pain that you have? How do you tell them? I mean, what is your approach to tell the people that these pains are not normal? It is not in that patient's head.
Yeah, absolutely. I mean, I think number one, allowing them to express how they feel in their own words is really important. And at least for adolescents, you know, I think that the more objective you are with the questioning, it's helpful. So I always have them tell me what their pain is on a scale of 1 to 10. 10's the worst, you know, and maybe, you know, think about it as like dental pain, you know, think about your dental pain experience and what was the worst, and describe your pelvic pain. And so, you know, if they're really sort of above the level of 5 and it's persistent, it's taking them out of activities, this simply is not normal. This does not give them a quality of life, whether they're just going to school or they're trying to participate in clubs or sports or their favorite activities. And if they are taken away from those things, they're losing opportunities. It's hard to concentrate in school. It's hard to take steps forward toward all the goals that they have. And so definitely, we say that it is a multi-pronged approach. We want to look at everything. And I think the hardest thing in these patients is that the bladder is near the uterus and the fallopian tubes and the ovaries and the rectum and the ureters, the abdominal wall. There are lots of things that we have to think about. And so there are some cases in which the complexity lends itself to a multimodal evaluation with multiple specialists. And in the end, we still may pursue a diagnostic laparoscopy to evaluate for endometriosis. And then post-diagnosis, they need support too, because many of them have chronic pain that is also concurrent musculoskeletal related. And sometimes they're going to need physical therapy to heal from surgery. And as their augmented medical therapy pairs with their surgical management.
Well, we appreciate you helping all the patients with endometriosis, especially very young adolescent. You have been involved with this. We appreciate your good, thoughtful present. And also you, as I said, you have been one of the early advocates for young female patients that they have endometriosis.
Yeah.
Do you have any other advice, any other opinion, anything, how you want the patients come and see you in Texas? Do you have any recommendations?
I mean, I think number one of the common questions that we get is that, is it possible for young girls to get their periods earlier than 12? Yes. I mean, it's possible for young girls to get their periods as early as 8. And so I think that while we're talking about adolescents, you know, we still have sort of that even younger population between the ages of 8 and 12. And if they have started their cycle and they're having these symptoms, they should come and see us. And while kind of our ACOG and NASPAG, our kind of parent organization for pediatric and adolescent gynecology, recommends that young girls come and see a gynecologist between the ages of 13 and 15, the reality is if they're having problems sooner than that, they should come see us before then. We see patients from birth to 21, and they can easily access our website.
Well, thank you very much for your participation, and forward we go.
Forward we go.